So rate control, a lot of patients will come to the emergency room for evaluation or go to the doctor's office because they feel a palpitation, they're fatigued, they're short of breath, or they're lightheaded, dizzy. So controlling the ventricular rate in atrial fibrillation is crucial. So we have two strategies. And we talk about a rate control where we control the heart rate, we lower the heart rate. And then we have another strategy we call rhythm control, where we try to convert the heart back to normal rhythm and try and maintain the normal rhythm. So we're going to discuss uh, those two strategies. But first, we'll concentrate on rate control. So patients who experience AFib-related symptoms during activity, the adequacy of the heart rate should be assessed, and you adjust the medicine accordingly. So you see, we have a class one. Everything we do in medicine, we rate it in terms of what is the class of recommendation. And so what they're saying here is that you not only have to try and control the resting rate, but you have to exert the patient. You let the patient walk around, put them on a treadmill, and see if how well the heart rate is controlled. Because if you don't do that, the patient, the patient may have very rapid heart rate during activity, and they may have shortness of breath, fatigue, and stuff like that. So you should do that. So that is a class one indication to control the rate. All right. So when you control the rate, we usually use a few medications, and then the physicians here. What you need to do, you need to know about three drugs very, very well. You know that there are others there that you can pull when you need it, but you need to know about two or three medicine very, very well, because rate control is very important. Your patient come to you and they have a rapid heart rate, and if you don't control the heart rate in a timely fashion, they're gonna remain symptomatic, and they're probably gonna go elsewhere. So the medicines that you should know about is beta blockers and your non-dihydropyridine calcium channel blockers. So know about two good beta blockers that you can use. PO, you know, if you're gonna, metoprolol is one of those that you should use. Some place in the world they use bisoprolol. In the United States, we don't use that too much, but there are other beta block, propranolol. Just know a couple and know how to use them very well. Then the non-dihydropyridine calcium channel blockers like your cardizem and your verapamil. Um, Select one and know that one very well. Most people would go to cardizem, diltiazem. Um, and you can use these medication in any type of atrial fibrillation, your paroxysmal atrial fibrillation, persistent, or your permanent atrial fibrillation. Sometimes you have to use intravenous beta blockers, and again, you don't have to know all the intravenous beta blockers. Most people would go to IV low pressor, okay, IV metoprolol. Some people like esmolol. So, whichever IV beta blocker you're going to use, know it very well. And the dose, you have to know the dose. So, um, and you can use IV calcium channel blockers, your cardizem and your diltiazem. Um, and something that I'm going to stress over and over is if the patient have atrial fibrillation and evidence of pre-excitation, and I'm going to explain what that is. Your best bet, if if it looks like pre-excitation, Do not use any medicines. Okay, the recommendation is going to say you can use uh, you can use one of the antiarrhythmic, and but I'm going to tell you, if the patient have a rapid heartbeat, you shock the patient. This is one of the conditions where you can kill the patient. So patient comes in with atrial fibrillation and evidence of pre-excitation, and you give them beta blockers or you give them calcium channel blockers, and they're going to VF and die in you. And you wonder what happened. So if you suspect pre-excitation, and how you're going to suspect pre-excitation is looking at the ECG. Okay, so the patient is in atrial fibrillation and they have a wide, bizarre QRS complex looking like a ventricular beat. But when you look at it, the QRS is sort of slurred. The QRS is sort of slurred. And the heart rate is very rapid, irregular, because that's atrial fibrillation. If you're not sure, you're going to err on the side of safety and you shock the patient. Okay? And so you not only want to control the heart rate resting, you have to exercise the patient, because most patients somewhat okay when they're at rest, but once they walk or move around and the heart rate goes very, very high, the patient becomes symptomatic with shortness of breath, fatigue, dizzy spells and stuff like that. So again, with atrial fibrillation, remember the atrial rate, is probably 300 to 600 beats a minute. It's a good thing we have the AV node, which slows a lot of those impulse that is coming from the atrium. So it's going to slow the impulse in the AV node. So it's only a few is going to get through. And usually the maximum rate that the AV node can process impulse coming to it is about 180 to 200 beats per minute. And that's a protective mechanism. So that's protective. So even though there's 400, 500, 600 impulse coming to the AV node, it can only process about 180 to 200. So the ventricular response, when you check the patient's heart rate, it's not going to be more than 180 to 200. But if this is a patient who have prior cardiac problems, they can go into heart failure with that rapid heartbeat. And not only that, but if you leave that rapid heartbeat and you don't treat it, they can develop something we call tachycardia-induced cardiomyopathy. That is, the rapid heartbeat can weaken the heart muscle over time and they develop heart failure. So you not only want to reduce the rate for symptoms, but you want to reduce the rate because of what a prolonged rapid heartbeat can do. Class 2A, so if your regular medications are not working, so the patient comes into the emergency room and you're going to get a couple of patients like this. You use your IV beta blocker, you use the IV calcium channel blockers, and it's not working. You can use IV amiodarone, especially in critically ill patients, to control the rate. So you can use IV amiodarone. Some older patients, nothing works. Your IV beta blocker, your IV calcium doesn't work. So some of those patients, what we have to do is ablate the AV node. Ablate the AV node. So you sever the communication between the atrium and the ventricle, because remember, with atrial fibrillation, the problem is that 400, 500 impulse that coming from the atrium is gonna go to the ventricle. So if you sever the electrical connection between the atrium and the ventricle, and that is what we call AV nodal ablation. You're going to sever that electrical connection. So that impulse that coming down, uh, coming through the atrium is not going to go to the ventricle. However, in those patients, you have to put in a pacemaker. So you have to put in the pacemaker. So about 4 to 6 weeks before you do your ablation, you put a pacemaker in, you bring them back, and then you do the AV ablation. So you don't have to worry about rapid ventricular response. However, you didn't treat the atrial fibrillation. The atrial fibrillation is still there. So those patients, you have to give them anticoagulant. Okay. So again, we can use amiodarone for rate control. I personally don't recommend it, but it is, you can use it. Now you have to know class 3 indication in whatever you're doing, because class 3 means you should not do it. It can cause harm to the patient, and it can be dangerous. So your AV nodal ablation and a permanent pacemaker placement should not be the first strategy that you use. So the patient comes in, you give them a couple of medicines and say, no. You have to exhaust your medications in trying to control the ventricular response. And if you cannot, and each time they're going to AFib, they become very symptomatic, going to heart failure. And if if it's a very difficult patient like that, and especially if there's an older patient, then you can go with your AV nodal ablation and permanent pacemaker placement. But that should not be your first strategy. Okay. And again, if the patient is in heart failure, you should not use your non-dihydropyridine calcium channel blocker. So if the patient, have a heart failure ejection fraction 30%, you probably should stay away from the diltiazem and the verapamil, because those are negative inotropic medication, and they can make heart failure worse. So that, and then we come back to your patient with pre-excitation. So this is a real phenomenon, and if you go to any big hospital in the United States, they will give you horror stories. Interns just coming on board and they see atrial fibrillation. They know that you need to pull IV beta blocker or stuff, and they didn't look at the EKG properly. Didn't realize that this is a patient atrial fibrillation with pre-excitation, and they give them IV beta blocker. They go into VF and they die. So you don't want to fall in that trap. So you need to look at your ECG. The only IV medicine that you should give, if you're going to give anything, is procainamide. So, and that's an exam question for people who doing exams. They're going to give you someone with atrial fibrillation, pre-excitation. Um, so it's going to be atrial fibrillation, rapid ventricular response. The QRS is going to be wide. It's not VIA. It's not VT. It's not ventricular tachycardia, because it's going to be irregular. And if you look carefully in some of the QRS complexes, you see the uh, slurred R wave, and they will ask you what to do. That the medicine you're going to give is your IV procainamide. Procainamide. You don't want to give no medication that's going to block the AV node. You don't want to give that, because these patients with pre-excitation, what they have an accessory pathway that connects the atrium to the ventricle. So they don't use the AV node. These patients, they do not use the AV node. The impulse comes down the atrium, it jumps on this bypass track and goes straight to the ventricle. Remember, the importance of the AV node is to slow impulse coming from the atrium to the ventricle. So if these patients with this accessory pathway, so for instance, they have, so, okay, so a question was, do you mean WPW? Yes. So WPW, Wolf Parkinson White syndrome, is a type of accessory pathway phenomenon, and there are multiple different names. Some don't even have a name, but you have it's a connection between the atrium and the ventricle, which bypass the AV node. So if you give a medication to block the AV node, this impulse is going to preferentially travel down the accessory pathway. So atrial fibrillation, the atrial rate is about 4, 5, 600 beats a minute. So if you block the AV node and you're encouraging the impulse to travel down the accessory pathway, so a lot of these accessory pathways, yeah, they can transmit 600 beats a minute, not the AV node. But these accessory pathway, no problem, 400 beats a minute. You put that patient with 400 beats a minute, they're going to go into ventricular fibrillation and they're going to die on you. So you don't want to do that, okay? All right, so that's pre-excitation. No medication that block the AV node should be given. The only medicine you can give is IV procainamide and shock the patient. So if you have a patient and you think it's pre-excitation, heart rate 180 beats per minute, systolic blood pressure 90 millimeters mercury, shock the patient, okay? Okay. Now, your dronedarone, which is your Multac. So it is similar to amiodarone. The only difference is that it lacks the iodine moiety. Um, so, you know, if you have a patient with, say, permanent atrial fibrillation and you have not converted them, you're trying to convert them to sinus rhythm and you just can't. You should not keep them on dronedarone or Multac for any prolonged period of time, because these patients can develop all sort of problems, okay? So if the medicine is not working to either maintain sinus rhythm or to convert the patient to sinus rhythm, you want to stop it. So again, when the heart rate is very rapid, patients gonna, they're all different type of symptoms. Some patients will tell you they feel lightheaded and they get dizzy. Some patient will tell you they're short of breath. You know, because the atrial fibrillation with rapid ventricular response can put them into heart failure, especially if they have like some valvular pathology, so mitral stenosis, or they have diastolic, uh, uh, diastolic dysfunction. That can put them into heart failure. So when you reduce the heart rate, you're really reducing morbidity. You want the patient to feel better. And rate control can be your only strategy, just to control the patient heart rate. And, of course, if they meet the criteria for anticoagulation using the CHA2DS2-VASc score, then you're going to give them anticoagulants, okay? And again, tachycardia-induced cardiomyopathy is a real problem. It's a real problem. And so you want to get these patients quickly and try and get the rate down. I have had numerous patients, and one sort of sticks out in my mind. Whenever she goes into atrial fibrillation, within a few days, she goes into heart failure. Her ejection fraction will fall from 65% down to 30%. So she goes into this tachycardia-induced cardiomyopathy very, very quickly and goes into heart failure, have to be admitted. So you don't want to, so those patients, you're going to try and convert them. So you slow the rate, yes, but those patients, you should convert them to normal rhythm. You don't want to get in the trap where, okay, you say that because the patients have a reduced ejection fraction, the atrial fibrillation is a result of that. You need to think the other way as well, okay? Because it's more than likely it's probably tachycardia-induced cardiomyopathy, And if you just convert that patient to sinus rhythm, you can get rid of the heart failure. So sometimes, patient think you're God because, they have this ejection fraction of 20%, and you convert them to sinus rhythm, and in a few months, their ejection fraction is back to 60%, and they were told that once the ejection fraction is that low, you can't do anything. So, you have to think broad. So the agents that we use to control the heart rate, beta blockers. So beta blockers is one of the mainstay. You need to know a couple of them, know it very well, know the dosing, the side effects, stuff like that. Um, I'm not going to tell you which ones to know. A lot of people will use metoprolol. You can use propranolol. Um, if you're accustomed to use bisoprolol, that's fine. You use carvedilol in specialized, especially if the patient does have a reduced ejection fraction even before the atrial fibrillation, then carvedilol will be beneficial. And then you have the non-dihydropyridine calcium channel blockers, which is your verapamil and your diltiazem. So a lot of people would use diltiazem, IV diltiazem. So know it very well. You have to know the dosing and the side effects of it. Digoxin. So even though digoxin is an older medicine, we still use it. You know, you remember if the patient blood pressure is borderline, systolic 90, and you give a little bit of IV cortisone or beta block, if you give too much, the blood pressure can fall and will fall. So in that situation, you can give IV digoxin. You give your IV digoxin, it's not going to affect the blood pressure. Okay, it will lower the rate. And you can load the patient. You can load the patient with your IV digoxin. That is about 1.5 milligrams in 24 hours. If you're loading the patient, don't get a level. Don't get a level because the level is going to be high. So again, we can use amiodarone and sotalol, which is another medication for rate control. We don't use these medicines for rate control, um, often because these are antiarrhythmic. And when we go to rhythm control, we'll talk about them a little bit more. But if your beta blockers and your calcium channel blockers are not working well, you can use these medicine for rate control. So again, the medicine, the agent that you're going to select depends on the patient's symptoms and degree of symptoms. Of course, if the patient is hemodynamically unstable, atrial fibrillation, heart rate 180 beats per minute, systolic blood pressure 90, the treatment for that is to shock the patient. The patient is hemodynamically unstable, so you have to convert them. Again, people who do an exam, they expect you to know that. So you shock the patient. If the patient is hemodynamically unstable with any type of arrhythmia, and they're hemodynamically unstable, that is usually systolic blood pressure less than 100. So you shock them. If the patient have heart failure, yes or no, then there are certain agents. If the patient have systolic heart failure, even before, not atrial fib tachycardia induced, you want to, carvedilol is probably the best medicine to use for rate control, along with IV digoxin. Those are good. You don't want to use, you have to be careful about IV diltiazem and IV verapamil in those patients because those medicines have negative inotropic effects and can make the heart failure worse. So you don't want, they can precipitate the heart failure. Okay? Patients who have COPD or asthma, and then we come to pre-excitation again because, if you go to the emergency room, you'll find that or overzealous resident or intern who didn't pay attention to the ECG give the patient IV beta blockers, and the patient go into VF and die. Okay, so you have to look at the patient, whatever else is going on with the patient. So if the ventricular response is very rapid, you want to use IV medicines. And again, know a few of the IV medicine, know it very well, and those are your go-to drugs. Know that there are others that you can use. So, since you don't use them that often, you may have to, read it up quickly. But have a couple go-to medicines that you know very well. So patient comes in rapid atrial fibrillation, rapid ventricular response. I would use, if there's no contraindication to IV cardizem, I give them a bolus of IV cardizem. If there's contraindication to cardizem, so I'll bolus them with 20, and then a few minutes later, you can give them another bolus of 25. Okay? I don't use verapamil a lot, but if it's a situation that the patient is, say, allergic to IV cardizem, then I might have to quickly look up the dose. 5 milligrams of IV verapamil, so beta blockers. I would use IV low pressure, which is metoprolol tartrate. You can use 2.55, milligrams, and you can repeat it accordingly. So those are your IV medicines. You have esmolol as well. Some institutions use esmolol. That's another beta blocker. So know a couple of them well, know how to use it, the side effects. And again, patient who comes in hemodynamically unstable, they may be in heart failure. So the atrial fibrillation may put them in heart failure, or the blood pressure may be low. Then you shock the patient, okay? So again, these are the patients that you're going to do electrical cardioversion, heart failure, ongoing myocardial ischemia, or if the patient is hypotensive, hypertension. So if you're going to use beta blockers, these are the different type. Esmolol, some institution, IV, esmolol is very, very short acting, very, very short acting. So you give them the IV esmolol, you put them on a drip, and it works beautiful because, again, you turn it off and the effect goes away. You can use IV propranolol. The dose is like 1 milligram, and you can adjust it accordingly. Metoprolol. So you can use, so that is my go-to medicine. When I remember when I was doing my fellowship, my go-to was esmolol, but a lot of places don't have esmolol, but metoprolol. You can use oral atenolol. Not a lot of people use atenolol, but you can use atenolol, propranolol, metoprolol. So remember, sotalol is an antiarrhythmic. So we do not use sotalol for rate control usually. Sotalol is mainly for antiarrhythmic. So it's a class 3 antiarrhythmic. So again, you can use it, but it's not widely used. Nadolol and sotalol not widely used. Again, carvedilol and digoxin if the patient has systolic heart failure. So, even though digoxin is an old medicine, it's still pretty good, still can use it. And then the calcium channel blockers, verapamil. I think most institutions use cardizem, IV cardizem. Patient comes into the emergency room, heart rate 150 beats per minute. Blood pressure is okay. You give them a bolus, and you can repeat the bolus. So you give them 20, you can repeat to 25. You can give them a drip. So you can give them a drip to lower the rate. I personally do not use cardizem drip. I prefer to give repeated bolus and then give them a PO medicine to lower the rate and keep the rate down. But you know. Um, and again, you know, these medicines, the verapamil, diltiazem, they not only reduce the resting heart rate, but they reduce the exercise heart rate and improve exercise tolerance. So that's what you want. The thing about digoxin, it does not decrease exercise heart rates. Um, so again, you should not use your non-dihydropyridine calcium channel blockers in patients with LV systolic dysfunction. So patient, you get the rate down, say 80 beats per minute, still AFib, 80 beats per minute, but the patient have an ejection fraction of 30%. You do not want to use verapamil and you do not want to use cardizem. It will make the heart failure worse. So you stay away from those medicines. If the patient have heart failure with preserved ejection fraction, you can use it, however. And again, pre-excitation, something like WP-double. So if you have a patient with WP-double and they go into atrial fibrillation, you shock them. Okay, you can use IV procainamide, but do not get your cardizem, do not get your metoprolol, do not get your digoxin. Okay, you will kill the patient. So again, these are some PO medicine, well, PO and IV medicine. So the metoprolol tartrate, you can use 25. So the tartrate is a short acting. So we dose it twice per day, 25 to 100 twice per day. You can, what I do, because you can't have the patient in the hospital forever. So if I have a patient and the patient comes in, I give them IV cardizem and the rate is down, but it's hovering about still 110, 120. I would give them metoprolol tartrate, say 25 or 50 Q6 hourly. And then once I control the rate, then I will, say 50 Q6 control the rate, then I give them 100 BID. Okay, and then once they're stable on that, then you can send them home. But this is the dosing uh, frequency for metoprolol tartrate. The IV metoprolol tartrate, so 2.5 milligrams IV over 2 minutes, and you can give them up to 3 doses. So they come in and the heart rate is 180 beats per minute, and you want to go with IV metoprolol, you can give them 2.5 or 5, and then you can repeat the dose and get you want to get that heart rate probably below 100. Are you comfortable? Um, the long-acting metoprolol is the metoprolol succinate, and that is dosed once per day. So if the patient have a problem with compliance, you may want to switch them from metoprolol tartrate to the succinate, and the dose ranges 50 to 400 milligrams daily. Or de novo, you may want to put them on metoprolol succinate. So again, know a few medicine, know it very well, and use it. Atenolol is an oral medicine, and 25 to 100 once per day. Esmolol, again, works very, there's no PO esmolol, it's an IV formulation. So you can, lower the rate real quickly and then put them in a drip, and then you can get them on, your PO metoprolol tartrate or PO metoprolol succinate. Propranolol, there's IV formulation, 1 milligram over 1 minute, and you can repeat the dose. And PO, 10 to 40 milligrams 3 times or 4 times a day. There's a long-acting propranolol, so you don't have to dose that frequency. There is now a long-acting propranolol. Nadolol, you can use PO, this is the range. Carvedilol, remember patient with ejection fraction, low ejection fraction, atrial fibrillation. This is probably a good medicine, carvedilol. And you can dose them 3.125 to 25 twice per day. Again, know only a few of the medicines. Beta blockers are beta blockers. So know a couple of them and know how to use it very well in this situation. And then bisoprolol is another beta blocker used mainly in Europe we don't use a lot in the United States, but and I think in the Caribbean they use it too. 2.5 to 10 milligrams. Then your non-dihydropyridine calcium channel blockers, the verapamil, know the IV formulation. So patient rapid heart rate, you want to lower it quickly, you can use verapamil. You can give PO verapamil over time. Uh, the diltiazem or cardizem, so you can know the bolus dose. So it is 0.25 milligram per kilogram. I don't go through that. They call me at 12 midnight. I bolus the patient 20. If it's still give 25, So again, know a few medicine, know it very well. And then this is the PO, the long acting formulation. So 120 to 360 once per day. Digoxin is still very good because that patient who is hypotensive, drawing for digoxin, loading them. So the maximum over 24 hours is 1.5 milligrams over 24 hours. So what I would do is give them 0.25 milligrams IV Q6 hourly, uh, you know, and over time. So it's not a medicine that's going to work right away. It takes time. So in about 8 hours, you're going to see the rate comes down real nice, real nice. And again, you can use amiodarone for rate control. I have never used amiodarone for rate control. Amiodarone is an antiarrhythmic. It is a medicine we use to either convert the patient to sinus rhythm or to maintain sinus rhythm. Um, Again, digoxin is not usually a first-line therapy. It takes a longer time. Onset of action is more than 1 hour, peak in about 6 hours. So don't expect to get the effects from digoxin, say 8 hours, 10 hours. But once you get that, it's a lasting effect. Okay, so it's not optimal for rapid rate control. Um, and again, it's not good for exercise heart rate. So if the patient have a problem with whenever they do any activity, the heart rate goes very high, digoxin is not a medicine that's going to help them, and either non-dihydropyridine calcium channel blockers or beta blockers. So it improves the ventricular rate when it is combined with your calcium channel blockers or beta blockers, but not by itself. And again, if the patient has systolic heart failure, it may be beneficial. So that's digoxin. Yeah, you have to know the problem with digoxin. You can get AV blocks. You can get ventricular arrhythmias. Those people who do an exam, they usually talk about a bidirectional VT. So bidirectional VT in a patient on digoxin toxicity, as proven otherwise. It can aggravate sinus node dysfunction, and you're going to make adjustments for renal problem, renal dysfunction, the elderly patient. And drugs that can reduce the excretion of digoxin, say amiodarone, propafenone, non-dihydropyridine calcium blockers. So if the patient is taking these medicines along with digoxin, it can elevate the level. And one of the reasons why we shy away from digoxin over the years is because a high digoxin level is associated with increased mortality. Most of the studies have shown that. So and that is why digoxin has gone out of favor. Okay, so if you're using digoxin, make sure that the digoxin level is less than 1.5. Okay, make sure the digoxin level is less than 1.5, because for whatever reason, the high digoxin level is associated with increased mortality. And again, you don't want to use it in pre-excitation. So patient with atrial fibrillation and double P double, no AV blocking medicines. So amiodarone. What amiodarone does, we use it mainly as what we call an antiarrhythmic, but it has sympatholytic and calcium antagonistic properties. So it depresses AV nodal conduction. And You can use it for rate control. Um, I have never used it for that. Uh, you know, because amiodarone does have potential toxic effects. So you want to make sure it's rhythm. Well, for me, it's rhythm. Okay. Uh, the dronedarone, which is the Multac, the only difference between the dronedarone and amiodarone, it lacks iodine moiety. So some patients are allergic to iodine. So you can give them the dronedarone instead. It slows resting and exercise heart rate. It should not be used for rate control in permanent atrial fibrillation. So if the patient is in permanent AFib, you can't convert them to sinus rhythm, don't put them on Multac. It increases strokes, heart failure, and cardiovascular death and unexplained hospitalization. So you just don't want to just leave. I've had patients, I've had it, they were on the Dronedarone, the Multac for a few months, and they like the medicine, but it's not doing what it's supposed to do. And then I ready to take them off of it, and they bitch and moan because they want to stay on it. So you have to explain to them why you're not keeping them on that medicine. Now, you may do everything to control that ventricular rate: IV cardizem, IV digoxin, IV beta blockers. You know, you may do everything to control the rate, and you just cannot control the rate, especially in some older patients. Rate 180 beats per minute, and over time that can weaken the heart muscle. The patient feel lethargic and tired. You may have to do AV nodal ablation, but if you're going to ablate the AV node, that means you're going to sever electrical connection between the atrium and the ventricle. So if you remember your conduction pathway, the sinus node is the pacemaker of the heart. It fires, anywhere up to about 100 beats per minute. And then the subsidiary pacemakers, the AV node, will come in at about 60 beats per minute, and anything below the AV node probably 40. So if you sever connection, you ablate the AV node, the heart rate is going to be inadequate. The heart rate will be inadequate. So some patient may have a heart rate of 40 beats per minute. Some may even go as high as 60. But majority, some of these older patients will have a heart rate 30s and 40s, and that is not, you're gonna take away one illness and give them another sickness. So you have to put a pacemaker in where it can increase the rate. Okay. So what you would do in those patients, you'd put the pacemaker in first, and then you bring them back 4 to 6 weeks later, and you ablate the AV node. So you're going to get rid of that rapid ventricular response. So some of these patients, the symptoms improve. Okay. Um, so you don't have to give them any medicine for rate control. However, those patients still need anticoagulation. They still need blood thinners. So you're going to put them on the CHA2DS2-VASc score and see, if they need anticoagulation. If you score them and they score 2 and above, then they need anticoagulation. Okay. Um, there was a few studies looking at what is the optimal heart rate. What is the optimal heart rate? I mean, should you get the patient heart rate below 60 beats per minute? Should you get the patient heart rate below 100 beats per minute? So the AFFIRM trial, in the AFFIRM trial, the AFFIRM was one of the studies that look at, should you do rhythm or rate control? Which one is better? Is rhythm or rate control? And so remember, when we say rate control, you get the heart rate usually below 100 and make the patient comfortable. Rhythm is when you convert the patient to sinus rhythm and try and maintain sinus rhythm. Well, their firm trials show that there were probably no difference in the two strategies. So, but the resting heart rate was less than 80 beats per minute. The average um, was about less than 100 beats per minute on the monitor. And about 58% of patients achieve that on the drug therapy. The RACE trial, which is rate control efficacy in permanent atrial fibrillation 2 trial. So the RACE 2 trial, where they had 614 patients, and they had a lenient control. So they tried to get the heart rate below 110 beats per minute, and then so one harm, you have the lenient rate control. The next harm was the strict rate control, where the heart rate was less than 80 beats per minute. And what they found out, so the composite endpoint, so what they were looking for: cardiovascular deaths, hospitalization for heart failure, stroke, embolism, bleeding, and life-threatening arrhythmic events. There was essentially no difference. For the lenient, it was 12.9% versus 14.9%. So should we go for this strict rate control, or just get the heart rate, below 110, 100 beats per minute, and see how the patient does? It depends on the patient, though. If the patient tell you that they're feeling good, then they're feeling good. If the patient say, I'm fatigued, I'm lethargic and stuff, then you may still want to get the rate down to where they feel much better. So the optimal heart rate, depends on the degree of the symptoms that the patient have. You don't want to treat so that the patient feels beter. And comorbid conditions that you're going to look for: valvular heart disease, left ventricular systolic dysfunction, because patients with these problems tolerate atrial fibrillation poorly, and you may have to get the rate really low. Heart failure and the presence of pre-excitation. So everywhere you say pre-excitation. So again, people who are doing exams, pre-excitation, double atrial fibrillation with rapid ventricular response. If you don't see IV procainamide, you're going to shock the patient, okay? All right, so when you get a patient with atrial fibrillation, rapid ventricular response, and it come to you, if they have no other cardiovascular disease, then you can use either your beta blocker, your diltiazem, or verapamil. Know one or two, know it very well, know how to use it, because if they call you 2 in the morning, you don't want to be fumbling and stuff. You need to know, if you want to go back to sleep as a physician, you better know your dosing real quick. All right. If the patient have hypertension or heart failure with preserved ejection fraction, then you can use your beta blockers, your diltiazem, or your verapamil. LV dysfunction or heart failure, then beta blockers or digoxin. And if the patient have COPD, be careful of using beta blockers, because that can aggravate the COPD. But your diltiazem and verapamil is when all else fail, amiodarone is there. Okay, so that's rate control in a nutshell. The important thing is not to use IV, or not to use any AV nodal blocking drugs in patient with pre-excitation. You have beta blockers and non-dihydropyridine calcium channel blockers to slow the rate. You can use IV if the rate is very fast. If the rate is not very fast, you can go with PO. Make sure you treat the patient so that the patient is symptom free, or the symptom is reduced quite a bit. If the patient is unstable, you're going to shock them. Heart failure, ongoing myocardial ischemia, hypotension. Patient is unstable, and atrial fibrillation, shock the patient. Okay, so we will talk about rhythm control. So this is rate control. We'll talk about rhythm, and that is when we convert them to sinus rhythm, and we try to maintain sinus rhythm. And then when we finish rhythm control, we'll do the updates. Okay, so we're going to stop here.